All right, good morning. How many people do we have online? Two. Wow, you got a big crowd today.
It's been an average of, I don't know, 25 to 40 today. It's been actually, numbers are good.
Excellent. All right. Yeah, probably so. All right. Well, thanks for having me again. I feel like I've done this lecture for you guys a million times, so I tried to change it up just a little bit here and there. It really hasn't changed a lot through the years, right, since we've known it. But the LVAD, so left ventricular assist device, actually was started in Baylor in 1962. Kind of hard to believe. In 1966 or 63, they put the first one in an actual patient. Didn't go well. In 1966, they successfully put one in, and the guy was 37 years old and he lived for 10 days. So they considered that successful because they were able to keep him alive for 10 days. And then the first long-term one actually was quite a bit later, was in 1988. So since 1988, we've had pretty good success, obviously, with LVADs. And contradictory to what Dr. Foth said, a lot of people will continue to live with an LVAD instead of choosing to have another open chest surgery. Mm-hmm. I'm pretty sure if somebody opened my chest and I felt okay and I felt like I could tolerate life, I would not let you open my chest again to chance a heart transplant. But that's just me. And it depends on how you feel, right? But there are 64 million people. I don't know how much of this he talked about, but there are 64 million people globally with congestive heart failure. And in the United States alone, we have like close to 7 million patients with heart failure. So I'm sure that the numbers are higher across the world because not everybody tracks it, I'm sure, right? But having almost 7 million people in the United States is a lot of people that are affected every day by heart failure. And the LVAD, like I said, really did kind of change things and make it so much better for patients that just are not amenable to medication treatment, right? So absolute contraindications have kind of changed a bit. So these are the current lists. If you guys have heard this lecture before, remember that the right ventricle has to be functional, right? Because that's where you get your preload. So if the right ventricle isn't working, an LVAD's not going to work for you. So that is an absolute contraindication. Then aortic or mitral valve disease, that's severe, obviously active infection, they're not going to put it in you. And now it's at about 75 years of age where they just won't go through that. If they can't control your hypertension or if you have severe peripheral vascular disease, they're not going to do it. And there are a crap ton of other contraindications that aren't absolute. So for instance, if you have severe cardiomyopathy and you have a really dilated ventricle, thick walls, they just physically can't put it in those patients. So there's lots of things. If you're maybe not I'm trying to think how to say this nice. If you're not the smartest tool in the shed and you don't have good family support, they're not going to put it in you either because they're not going to trust you to be able to take care of this device on your own. So like he talked about briefly, there's an inflow cannula, the VAD itself, which these days is implanted directly into the chest. The original model, the Heartware 2, I think it is, or the HeartMate 2, was 2 surgeries. Had to open the chest and the abdomen because the actual pump was in the abdomen. So, yikes. So now at least they can just open the chest. And I say just because it's not my chest. But then you have an outflow cannula. I'll show you pictures and videos here in a minute. And the drive line. The drive line is where it exits the body and goes to the controller and then to the power source. So here's the video. Let's see if it'll play. Ooh, that's loud. Sorry.
The Heartware Ventricular Assist System is a miniaturized implantable circulatory support system for the treatment of advanced heart failure. The Heartware system consists of a small continuous flow pump with integrated inflow cannula, an outflow graft with strain relief, a drive line, an external controller, and external power sources. At the core of the hardware platform is a proprietary suspension system for the wide-bladed impeller. Using a combination of both hydrodynamic and passive magnetic forces, a thin layer of blood is established between the impeller and the pump housing. During operation, there are no points of mechanical contact within the pump, effectively creating a wearless system. The LVAD pump, roughly the size of a golf ball, is capable of providing up to 10 liters per minute of blood flow. Its small size and integrated inflow cannula allow the device to be implanted completely in the pericardial space, directly adjacent to the heart, thereby avoiding abdominal surgery. The implant procedure makes use of a proprietary sewing ring and custom apical coring tool, which allow the pump to be attached to the apex of the left ventricle. The outflow graft is then attached to the ascending aorta. Once in place, blood flows from the left ventricle through the inflow cannula into the impeller. It then exits through the outflow graft to circulate throughout the body. The driveline cable, constructed with fatigue-resistant conductor wires similar to those used in pacemakers, exits the patient's skin and connects the implanted pump to an externally worn controller. The controller is powered by 2 lithium-ion batteries, or one battery plus an adapter connecting to a wall or vehicle electricity outlet. The controller operates the pump and features a 2-line LCD screen to display parameters, alarms, and recommended troubleshooting concerning the operation of the system. The controller and batteries are carried in a case, designed to be worn either around the waist or over the shoulder, enabling the patient to resume normal daily activities.
All right, so first generation pumps, which were the HeartMate 2, they were pulsatile. So they actually tried to keep up with the patient's intrinsic heart rate. So that was a generation 2 with the impeller. So they have a continuous flow, right? Actually, all 3 of those may be continuous flow. It may have been the HeartMate 1, but regardless, the HeartMate 2 is the one that's still in the abdomen. Probably less of those around than there used to be, but the HeartMate 3 and the HeartWare are both in the chest. And it's going to look something like this, right? I think this is probably the older version. It's a little bit bigger, but you can see it's pressed right up against the heart there. And then notice, pretty much they're all going to have a pacemaker, right? AICD. So the indications for an AICD alone is an EF less than 30% that is not amenable to correction by medication. So typically by the time they get to the point where they're actually getting an LVAD, they've already had the AICD placed, right? Because the risk of them going into VTAC, et cetera, is super high. And so they go ahead and place the AICD. I thought that was funny. All right, so the different parameters between the 2 machines, they both have speed. And the speed is going to be preset, right, based on how the patient's heart function intrinsically is. And they're both measured in revolutions per minute, just like you would measure speed in most things. Power is measured in watts. You can see that on both types of machines. Then on the HeartMate 2 and 3, it's a little bit different than the HeartWare itself. It will show an actual flow. And the flow is just a calculation of the power and the speed. So it's a result of both the actual device and what it's pumping, and then the pressure gradient between the inflow and the outflow cannula. So that's what you're going to see on flow on that. And then the pulsatility index and the waveform that you will see on the heartwear are both kind of the same thing. So pulsatility index is a measure of what the patient's intrinsic heart is doing. So when they put that in and they connect it, they will tell the patient your PI is 9, let's say. And so that is on the heartwear a waveform, because that's the only thing that's got a waveform, right? Is the patient's intrinsic heart rate, because that device is a constant flow. So the PI or the waveform is a measure of what the patient still is contributing to being alive, basically. So if a patient comes in or you pick up a patient and they say, man, I feel terrible. My PI is normally 9, it's 3. Something's bad wrong, right? Because they've lost their intrinsic heart function. And I've told this story before, but if you weren't here, I'll tell it again because it will forever live in my memory. But it was the last day of Dr. Cody McMillan's residency. And at that time, it was 4 years. So 4 years of training. Last day together, I go in the room with him. We have a patient with a LVAD come in, and she walks in the room and she said, I'm weak, I feel terrible, and my PI is low. Okay, have a seat. Because I didn't know anything about LVADs at the time, nor did my resident. It was just coming out. And so she lays down in the bed and they hook her up to the monitor. And I'm like, I don't know what a waveform is supposed to look like in a patient with an LVAD because I'm retarded. And I should probably know this. I'm an ER doctor and these things are out here, but that looks a lot like VFib. And she's talking to me, right? But I know that her PI is low, and I'm looking at the monitor and it looks like VFib, VTAC maybe, I don't know. I don't remember. It was not anything resembling a sinus rhythm. It was a ventricular rhythm of some sort. And so he keeps talking to her and I sneak out. And I don't know if you could know Dr. Nicholas, but thankfully he was on call that day. And I called him and I said, hey, John, I've got one of your LVAD patients here and she doesn't feel good. And she said something about her PI being low, but when I hooked her up to the monitor, looks a lot like VTAC. And he said, well, shocker, Leisha. And I was like, what? Well, before I could make it back in the room, because John is who he is, he raced to the room and was standing there talking to the patient, his patient, thankfully, and said, ma'am, we need to shock you. Your heart is in VTAC or VFib or whatever it was. And so he commences within 90 seconds to have her shocked and back in a sinus rhythm. And lo and behold, her PI goes up and we transport her back to her LVAD center. So that was a big learning point for me, you know, a moment where I was like, holy cow, I got to learn about this stuff, right? So that was really the day that I kind of took on training myself about LVADs. So if the patient tells you their PI is low, it's their intrinsic ability to assist in being alive. And she was alive only because of the pump, right? So she had lost all of her ability to contribute. So there's lots of things that can go wrong with these things, obviously, right? So suction events. The actual VAD has a sensor on it that can tell if something's stuck up against like the drive lines or whatever, not the drive lines, the inflow or the outflow cannula. And it responds by, I mean, you guys know if you have a hose or something running and something gets stuck up to it on a, you know, where you have an inlet to it, it's going to slow it down intrinsically, right? But then how do you get that off? If you slow down the flow, if you slow down the power, if you slow down the speed, it's trying to let that suction, whatever it is, did it get sucked up against the wall of the ventricle? But it's going to do all those things to try to get the suction to release to go back to normal flow, so that it can get the filling pressure that it needs. If it's a thrombosis, then it's going to try to speed everything up, right, to push that clot on through. So you have high flow and high power. So on the HeartMate which I think was the one in the video, you have two different icons. You have a battery and a heart. And if the battery is yellow, it's telling you, hey, I've only got 15 minutes or so left. You need to find a battery to get me hooked up to, or I'm going to die. Red is scary. You got 5 minutes. And a lot of these people will have an external connector as well. So you can actually plug it into a 110 volt. If the heart is lit up red, that means you have low flow or pump stoppage, like we talked about a minute ago. So here's an example. And if this alarm is going, and it's making all sorts of sounds, don't be afraid to push this button. It can be super annoying because they can be really loud and obnoxious. And you're not going to be able to change anything by touching buttons. So even if you touch the wrong one, it's okay. You're not going to hurt anything. And certainly you're not going to hurt anything by hitting that silence alarm. Hardware just has 3 alarm levels. So it'll be 1 light. If it's solid yellow, that's kind of a low warning. If it's flashing yellow, that's a medium warning. If it's a high priority, then it's going to be red. And so an example on this one is if it's a solid yellow, that may be the low battery state. If it's a medium, it could be thrombosis or electrical dysfunction. Interestingly, the electrical dysfunction of these, other than not having a power source, is pretty rare because they made a lot of redundancy to the wiring. And so it's really hard to get an intrinsic electrical malfunction, which is pretty cool, right? Like, I'm glad there's more than one wire there, especially if it's in my chest. But anyway, flashing red light means something's wrong. The pump has actually stopped. So then it's going to require intervention by us, right, to correct that. And this is just the same one that was in that video, which is the hardware. And that alarm indicator is right here. And if this is lit up, this is not going to show this. It's going to tell you what to do, or what it thinks you should do, or what it recommends that you do, i.e., hey, retard, I need a battery, something like that, right? Okay, so you can have a controller fault. You can have an electrical fault. Again, pretty rare to have an electrical fault because of the redundancy. You have high watts and it's just telling you that it's having to work too hard, or low flow, hey, I don't have enough pumping through here, something's wrong. So for you guys, the approach to management really, by everybody that talks about LVADs, is there should be a written protocol for you guys to follow. Do you guys have one? Probably not. Okay. So that's the recommendation by people who put LVADs in, is that every individual entity should have a written protocol.
Somewhere on that control box, there's a phone number.
Call it. Yes, and absolutely. That
pretty much what it is.
Yeah, so that is a big part of it, right? Is always contact the coordinator. So for you guys to let them know before they get there, that's a good idea, because then when we call, they're like ready to talk about John Smith from Joplin, Missouri, right? Don't forget to collect the spare parts that they have at home, batteries, yes, cords, whatever they may have, and always listen to the patient and the family, because again, like we talked about, if they're a simpleton, they're probably not going to have an LVAD. So these patients and their family members have been well educated. And, you know, if I would have listened to the patient better that day, I probably could have got her to tell me what her PI actually meant. You know, like, oh, that's my heart and I don't feel good and it's low, so my heart's not working well. I mean, if I would have asked her or talked to her more, and again, once I saw the monitor, I excused myself and let the resident keep talking. But they are very knowledgeable, so make sure and ask them questions. Like we talked about earlier, it's a continuous flow. If their PI is low at baseline, which obviously most of these patients don't have much, that's why they can't survive without the LVAD, they're going to have faint or no pulse at all, right? And that's okay.
Pretty much what ours is saying. Call somebody.
Yeah. Call 911. Oh, wait, I am 911.
Exactly. Put a few pictures of what they look like probably, and they may not, they may be updated. That's the heartbeat 3 that they have in there.
That's what I showed.
Yeah. I mean,
Contact for St. Luke's and Oklahoma Heart Institute.
yeah. Yeah.
It's probably posted somewhere on their machine.
Right,
That's
right.
what we've done about that.
Or they have a card in their pocket they're going to whip out and give to you. Yeah. Mm-hmm. Yeah. So constant whirring, if you put your stethoscope on their chest, is what you should hear, right? It's just a mechanical sound. And if you've never heard one and you know that there's a patient somewhere around with an LVAD, take an opportunity to listen to it, because it's very interesting to put your stethoscope on the chest and it sounds like a machine, not a heart, right? If you hear something that sounds like ice in a blender, which I can envision what that would sound like in my mind, that's bad, because that probably means that that machine has clots in it and it's actually chomping up the clots. So if it sounds like ice in a blender, that's bad. So mean arterial pressure is what you need to use. I know for you guys, easier said than done, right? Because normally, how do you get a mean arterial pressure? And it shows you on the machine, right?
Or that.
Yeah. So they're not going to be able to have that. And so we'll talk about that more in a little bit. But sigma manometer versus Doppler, well, you're going to need the Doppler to actually be able to get a map in these patients. And so more importantly for you guys, distal perfusion, do they have volume overload? Are they pink, warm, and dry, or are they sweaty and cold and their cap refills shit? Sorry, because it shouldn't be. But they really should be managed by what they look like for you guys in particular, because you can't assess the map that easily in these patients. So again, remember, they're all going to have an AICD or pacemaker and or combination. They shouldn't have any volume overload because the pump should be helping take care of that. But they all are going to have an increased propensity for bleeding, and we'll talk about that more in a little bit. So just have that on your radar for a multitude of reasons. Like I said, we'll talk about. And pulse oximetry may not really work in these patients just because the flow isn't the same. It's not there like it is in you and I, hopefully. But again, so rely on what they look like. Threw this in because I knew I'd drop a word in there somewhere. All right, so this is how we would do the map in the emergency department. So basically you put the cuff on, then you get your ultrasound out. Grasp the Doppler probe. Place the probe in the gel. Anyway, so you put it there where you would listen, right? And you wait to hear that. So it's not going to be the thump, 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 right, of taking a manual blood pressure, which y'all probably haven't done for a million years, but you're listening for that, and you inflate it until it goes away. And then just like you would listen for the thump, first place that you hear it, that's going to be their mean arterial pressure. You want it to be between 70 and 90 is your target. So again, I know you guys can't really do that, but that's the way that it should be measured to be valid, is do the mean arterial pressure with the Doppler. All right, so we talked about this a little bit with my scary story. So an EKG is going to show low limb lead voltage, electrical artifact, and probably what they call QRS splinting. And so it's going to look more like that than your normal QRS that you would see, right? So it's just got more stuff to it. But that would be a normal appearance of the QRS in a patient with an LVAD. So if they have a ventricular arrhythmia, like we were talking about earlier, the problem with that is that they're not getting the preload to their heart, right? Just like if you go into VFib or VTAC arrest, sitting here without an LVAD, you no longer have preload to your heart. So then you can't pump anything forward. So you have to terminate that, right? So the recommendation is, if you have to defibrillate one of these patients, is that you do the electrical and you give amiodarone at the same time. So they recommend doing both because then it prevents recurrence. Okay, I think that's all I have to say about that. So this is where we'll get into the multitude of complications that can occur. The GI bleeding, like we talked about, they actually can bleed anywhere, but GI bleeding is the most common place that you're going to see issues. Strokes, infections. If their right ventricle fails after they've already had it placed, that's a problem. You can have pump specific issues. You can have clot in the pump. All these things are complications. So the GI bleed in these patients is multifactorial. And one of the reasons that they're at a risk of bleeding is because they're all on Coumadin. INR between 2 and 3 for these patients. And another thing that happens in these patients, just because of the intrinsic nature of how the pump is providing your blood flow, normally we have an up down that puts stress on the arteries, right? And when you don't have that, it actually makes you susceptible to vascular malformations developing in the GI tract. So our bodies need that pumping through to keep it normal. And if you don't have that, then you're set up for creating like AV malformations, et cetera, which is how most of these patients bleed in the GI tract. The acquired von Willebrand factor disease, I think, is very interesting as well. So, you know, the little impeller that they showed and the blood flows through there, and it's not really supposed to be squishing anything, right? It's supposed to just be pushing it through there with no forces put on the actual blood cells. Well, in actuality, there is some force, right? Because it's going through that chamber and it's swishing around and it's hitting walls, et cetera. So the actual von Willebrand factor, the little multimer that makes it up, gets stress on it and it actually destroys it. So then inherently, you have no von Willebrand factor, you develop the disease and you're at increased risk of bleeding because you no longer have von Willebrand factor, which I find quite interesting that that's the only one that it seems to affect. It must be the smallest, the daintiest. I don't know, maybe it's the girl version of the clotting factors, but anyway.
We had a quick question on.
Yeah, sure.
Online, it says how much amiodarone should be given.
I would, if you are defibrillating, I would do the 300. Yeah. Yep. Anything else?
They're a little bit behind, so.
Oh, okay.
Cardio version, maybe would it be the 150?
I would think, because that's how we do it with everybody else, right? If we cardiovert, we give 150. If we're defibrillating, we give 300. So, yeah. Yeah. I didn't look it up, but I would think.
Yeah. Still 150, but it's in drip.
You have the push, though, right?
Yeah, we can get boluses.
Yeah. Okay. I think that was it on this one, unless there's another question.
Not currently.
Okay. All right. So stroke, high risk of stroke, either embolic or hemorrhagic. So we just talked about the reasons why they have an increased propensity for bleeding, right? The von Willebrand factor being destroyed, the fact that they're all on Coumadin, but they also have a risk of having a clot and having a stroke, just like half the population of Joplin, right? So you have a heart that is not doing well, it's failing, blood's not pumping in it, right? Because the actual blood that the ventricular assist device is pumping through, remember, is through that outside of the heart. So it's not actually pushing blood through the heart itself, right? So that blood is flowing continuously. Well, the blood inside the heart is not pumping as well as normal, which is part of the reason why they have to be on the Coumadin, right? But obviously that sets up the ability for the patient's heart intrinsically to develop a clot inside. And most of them are at a baseline AFib. So you can have embolic or hemorrhagic strokes. Another complication, infection. When this first started, I think maybe they weren't following like standardized infection precaution, because it was actually like 50% of the patients that developed infection pretty early on. They're down much lower now. And obviously you can't relate the placement of the device. If it's a year out, it's probably not the actual placement, right? It's coming through the driveline or something like that. So the most common cause is staph. And we would get a CT of the abdomen if the driveline is not obviously infected. You guys can obviously see the driveline exit, and that's going to be the number one place where infection is going to be. And obviously they can develop sepsis. I forgot to say over here, to reduce the risk of stroke overall, the 3 things that they do is recommend that their MAP never be over 90. They put them on a baby aspirin, and they never want the INR to be greater than 3. So you're playing the game with the clot versus the bleeding too much, right? Okay, sorry to go back. So infection, any questions on that? Moving on. Talked about the right ventricle has to be functioning well to give you the preload to do this whole rigmarole. And in 15 to 20% of patients, after the device is placed, will develop right ventricular dysfunction. And then they're going to be up Schitt's Creek, right? Because now they can't fill that pump and everything's just going to go haywire. They're going to present to you in cardiogenic shock, just like you would if you had heart failure without the device, right? And so you're going to have to treat them the same as you would with inotropes, et cetera. You may see a low flow alarm with that, right? So particulars for you guys. Obviously, CPR is okay. We've known this for a long time, right? When they first came out, everybody was terrified to do CPR because they said, oh, you're going to disrupt the pump, you're going to break a line, you're going to do something. Okay, well, they're dead, so you can't get much deader, right? And so finally in 2017, the American Heart Association got on board and said, hey guys, do CPR on these patients because they're going to die if you don't. All your usual ACLS drugs are okay. Fluids, be cautious, right? The patient has heart failure to begin with. But if they look dry and their PI is low and their volume depleted because they've had diarrhea for 3 months, obviously they probably need some fluids, right? Just like any other patient. We already talked about you can defibrillate. Their MAP should be 70 to 90. Again, that's hard for you guys. You can externally pace them. Bring all their equipment, like we talked about. Make sure you bring their batteries. And again, listen to the patient. All right, so what if you see this? What are you going to do?
How do you know if you're cardioverting or defibrillating if they have a constant blood flow?
How do you know?
Like in your patient, she was sitting there talking to you.
Right. Right.
But if she has an LVAD device, how do you know if you're...
So it's still considered the same, stable versus unstable. So if you had this and you felt like the patient was stable, you wouldn't necessarily have to shock them because you can cardiovert them. And you guys wouldn't do that, right? You pretty much just defibrillate, right? Do you cardivert? Okay. So you cardivert them if they're stable, or you defibrillate if they're unstable. So if they're unconscious, you see this, defibrillate. Well, right. Yeah, yeah. But I mean, it's the same. Cardioversion versus defibrillate is the same. If the patient's stable, you do, and if they're unstable, you do defibrillation, right? Right? And it happens with everybody, you know, it's not just you guys. The medical student goes in and they get your story and then they talk to the patient and they say, EMS said this, but the patient said this. And then I go in there and they're like, that's not what I said. Okay. What's the lie now?
I do have another question.
Yeah.
That particular rhythm right there, you're going to have a hard time cardioverting.
Right.
Because it's not going to capture.
Right. You just defibrillate that.
But they're awake.
If they're unstable, I would. Yes. If they're, so that brings to a Dr. Wright decision-making tree. I have a really hard time putting electricity in you if you're awake and talking to me. I just do. And the boys find delight in that. I do not, because if you come at me with an electrical cord and my eyes are awake and looking at you and I'm talking to you, I'm going to be pretty pissed off, right, if you light me up. So if I were you and they were stable and I were in your place, I would not shock them because they're awake and they're talking to me and, you know, they're perfusing and whatever. They just don't feel good. I would bring that to me and let me do it under sedation, or they may walk in and I just light them up. But for instance, a patient with bradycardia that I give them atropine and they don't respond, everybody's like, oh, let's externally pace them. Again, they're awake, they're looking at me, they're talking to me, and then grandma goes, ow, 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 every time she gets shocked. Well, screw that. We have medications for that, right? Number one on my list is isoproterenol if I need it. And we're digressing substantially, but again, it, you know, if the patient's stable, it's okay to not shock them, in my opinion. If that answers your question.
It does. It's just, I mean, we can sedate too.
Yeah,
Still,
right. But do you want to take the time to do that? And, you know, whatever. If you're 5 minutes away, right.
you don't want to withhold definitive care when you're just trying to make a decision.
Right, right. All right, so in a crashing patient, you're going to do ACLS as usual. Pulse checks should include Doppler. You're going to look at the monitor, try to figure out what's going on. Per your protocol, you're going to call the LVAD team and know that if you bring us a patient and you've already figured out that the stupid machine just isn't working, they're probably going to end up on ECMO because they're going to have to do something to mitigate that time until they can fix things or whatever. And then you guys are going to have to double transport all these patients, because if they're having a big issue and they call the ambulance and you bring them to us, then we're going to send them on once we stabilize them. Questions? And as per your prediction, Kyle.
I knew you'd be done.
And I tell stories even, like.
So it's good to refresh on the LVAD.
Yeah, even for me. I mean, I love doing this lecture just because I'll go a year without seeing one and I'm like, oh, yeah, I get to do the LVAD lecture and refresh my own memory.
You say, do you have many come in that you are?
Not very many.
Do we have any in the area right now?
I think that we have one. I was talking to the group the other day, and I think there's one right now. And it's the drug rep guy. You guys know who I'm talking about? Can't remember his name, but he coded in the ER, and he used to come in and call on us and bring us food all the time and whatever. And he had an LVAD, but he got a heart. So we don't have him anymore.
Do TPA drug rep guy?
What's that?
The TPA drug rep guy?
He was like Levaquin or something. Yeah.
Did the LVAD used to have a ruby in it? Do I remember that recall years ago that used to have like a little ruby when the blood passed through there? Is that?
I don't know.
I'm digging way deep, like 10 plus years or better.
So like in 1988 when they first put it in? I don't know.
Like early, I kind of remember some Mercy education.
Actual gym, the ruby.
Yes, and the blood crossed over it to give it something. If I can't remember, it's been too long ago. That's why I asked. Maybe it must have been my first gym.
Don't know. I'll try to look that up if I do this next year. Add a little tidbit.
Because it didn't look like they showed that on there.
That one does not have a ruby in it.
Yeah,
No.
it doesn't look like it. Well, that's what I was afraid of.
Don't tell the meth heads. Right, right. All right, guys. Thank you. Yeah.
All right, we're gonna sign off for lunch. We'll see you guys back.